Good evening, everyone. I am Dr. Akhil Bevera, and my topic for today is outcomes of photorefractive keratectomy, big data analysis over the past 10 years. As you all know, PRK is the first surface ablation method introduced in the late 1980s. It offers certain advantages like lower risk of postoperative ectasia, more residual corneal tissue for retreatments, and no risk of flam complications. However, many surgeons shy away from PRK mainly due to delayed postoperative recovery, long-term use of medications, complications such as corneal haze, and more sight-threatening complications like microbial keratitis. So the aim is to present the refractive outcomes following PRK in myopia and myopic astigmatism over the past 10 years in our institute. This is a retrospective review of 20,129 eyes of 10,223 patients who underwent PRK for myopia or myopic astigmatism between January 2013 and February 2023. So these were the examiner laser platforms that we used. For PRK, we follow a standard procedure. The epithelium is soaked in 0.5% proparacaine or 20% alcohol for 20 seconds. Then the epithelium is debrided in the central 8 to 9 millimeter zone with a hockey spatula. Then the stromal ablation is done, and then MMC is applied as per protocol that I'll be describing in the next slide. And then the BCL is placed. So for MMC application, we use 0.02% mitomycin C, which is applied directly to the stromal bed or through a Vexel sponge. And the duration is 10 seconds for every diopter of ablation or 10 seconds for every 10 microns of ablation. For postoperative regime, we use moxifloxacin 0.5% eye drops for 1 week, clotiprednol 0.5% in tapering doses for 3 to 6 months, and lubricants for 6 months. So these were the measured outcomes: UCVA, BCVA, manifest refraction spherical equivalent, and corneal haze. These were measured in pre-op, 1 month, 3 months, 6 months, and 12 months postoperatively. So moving on to the results, 85% of our patients were between 20 to 29 years of age, and there was a near equal male is to female ratio. The most common procedure performed was wavefront optimized PRK, closely followed by topography guided PRK. So the mean UCVA logMAR preoperatively was 1.14, which improved to 0.06 at 1 month postoperatively, which further improved to 0.03 at 1 year. And the mean BCVA was 0.02 logMAR preoperatively, which improved to 0.01 at the end of 1 year. So when we compare the preoperative BCVA with the post-op UCVA, we notice that 74% of our patients were within 1 line of preoperative BCVA at 1 month, and 85% were within 2 lines. This increased to 86% and 93% at 3 months, and 88% and 94% at 6 and 12 months. So the spherical equivalent of refraction was very stable. We noticed that there was a greater than 0.5 diopter change in only 8% of our patients between 3 to 12 months. So when we compare the accuracy of the spherical equivalent to the intended target, we noticed that 93% of our patients were within plus minus 0.5 diopters, and 99% were within plus minus 1 diopters at 1 month. This increased to 95% and 98% at 3 and 6 months, and 96 and 99% at 12 months. Now looking at astigmatism, again 91% of our patients were within 0.5 diopters of the preoperative astigmatism at 1 month, and 99% were within 1 diopter. This again increased to 95% and 99% at 3 and 6 months, and 96 and 100% at 12 months. The efficacy index was 1.79 and the safety index was 0.68. So when you look at the haze, what we noticed was that only 16% of our patients had grade 2 or more haze at 1 month, and this further decreased to 7% at 3 months, 5% at 6 months, and 4% at 12 months. We also did a preliminary subgroup analysis by dividing the dataset into 4 categories based on the preoperative spherical equivalent. So again, if we compare the postoperative UCVA with the preoperative BCVA, if you look at the first group, 80% of our patients were within 1 line at the end of 1 month, and 89% were within 2 lines. However, this was as low as 52% at 1 month in the fourth group, and 69% were within 2 lines. This gradually increased over the course of the follow-up period, and at 1 year, we noticed that 90% of the patients in group A, 92% in group B, 85% in group C, and 78% in group D were within 1 line, and 97% in both group A and B, and 92 and 87% in group 3 and group D were within 2 lines. And again, if you look at the accuracy of the spherical equivalent to the intended target, we notice that 96% of the patients and 99% of our patients were within plus minus 0.5 and plus minus 1 diopter in group A. Again, if you look at the group D, which is greater than 9 diopters myopia, it was 78% and 90% respectively. Again, these values also increased, and by the end of 1 year, you can see that 98% in both group A and B, and 93% in group C, and 82% in group D were within plus minus 0.5 diopters, and 99%, 100%, 97%, and 93% respectively were within plus minus 1 diopter. So again, when you look at the haze features, we notice that in the first two groups, we noticed that the grade 2 or more haze were noticed in less number of patients. However, this number increased in the second two groups. However, none of our patients had sight-threatening haze. So the conclusion I would like to say is that this is the largest series on outcomes of PRK till date. PRK is very accurate even in cases of high myopia. However, the recovery is slower for higher refractive errors, and sight-threatening haze is very uncommon due to judicious use of MMC and topical steroids. Thank you.
Thanks, doctor. I think excellent study. And you had not included trans PRK, I think, right, in this?
We did.
You had even that.
We had it. If you look at one of our slides, I think.
So which platform, and was there any difference? Did you do a sub-study between alcohol?
Not yet. That is planned right now, ma'am. We are planning to do with the present data set.
Okay.
So this was, we started off with this, and then we are going to go into the subgroup analysis.
You have compared this recovery with the flap also, I'm guessing, right?
No, we have not. We are not.
And what is the reason? I mean, what are the reasons why you see that improvement over the first year? So the slower recovery of what we see in PRK.
Yes.
What exactly did you do? Any epithelial mapping, and why does it improve so slowly according to your analysis?
So epithelium does actually play a very important role in recovery in PRK, which is actually not quite studied in detail.
So did you include that in the study as well?
In this study, no, but we have taken the epithelial maps.
You have taken it.
Yeah, we have taken, but we don't have epithelial maps for all our patients over the course, because we got epithelial mapping very recently, around 3-4 years ago. So we have for the recent data set, but for the last 10 years, we don't have the epithelial maps. But that is one aspect that we are already started looking into.
But I think no visually significant haze is a very good thing for such a large study. So do you have very strict exclusion criteria when you do high powers? What are you looking at?
So what we have is a very robust post-operative regime. For high myopia, we always keep steroids for at least 6 months post-operatively. And if you see our MMC protocol, this is something different that we follow, that based on the preoperative spherical equivalent, we take into consideration how much duration the exposure needs to be placed, and that has played a very important role for us in reducing our haze. When we switch to this, we notice that the haze has dramatically decreased in our patients.
I think we'll look forward for the epithelial study. That will be interesting.
Sure. Yeah.
Thank you. And these haze is all again clinical, yes. Right? You've not used pentacam or densitometry or anything. No. So there will be a subjective error.
There will be a subjective bias.
So you have like photographic grading, because grading is always you may feel 2, I may feel 3. So do you have a photographic reference or something? Because in LVP there are a lot of fellows who would also see.
Correct.
So how do you generally...
If there is clinically significant haze, we will get a photographic documentation.
Okay.
In those patients.
So based on that you are...
Based on that
Okay. It'll be nice if you add all those photos next time in the...
Sure.
So next is Dr. Divya Reddy.
Good evening everyone. Welcome to CareCon 2023. I would like to present a study done to evaluate and compare the effects of high fluence accelerated transepithelial collagen cross-linking performed using pulsed UV light and using a combination of pulse UVA and oxygen supplementation. The standard resident protocol involves removing of epithelium followed by UVA irradiation. This may lead to some complications like infectious keratitis, haze, and delayed epithelial healing, which could be prevented by the transepithelial collagen cross-linking where the epithelium is not removed. This is attributed for the lower efficacy of TCXL because it causes the limited diffusion of the riboflavin and 30% lower penetration of the UVA light and limited oxygen penetration because of the high metabolic activity activity of the epithelium. These drawbacks could be overcome by adding the substances which increase the penetration of the riboflavin, and by increasing the total energy from 5.4 to 7.2 joules, and by increasing the oxygen availability either by external supplementation or by using pulsing of the UV light. So the main objective was to evaluate and compare the ultrastructural effects of high fluence accelerated TCXL with and without oxygen supplementation. This is a prospective randomized comparative study. These are the inclusion and exclusion criteria. 45 eyes of progressive keratoconus, 15 in each group, were recruited by randomization. All groups underwent transepithelial collagen cross-linking. Group A was a control where continuous mode of irradiation for 3 millivolts for 30 minutes with a total energy fluence of 5.4 joules was done. Whereas in Group B and Group C, high fluence pulsed accelerated TECXL was done, where patients are exposed to 9 millivolt per centimeter for 13 minutes 20 seconds. The total energy will be 7.2 joules with pulse mode, where the UV light is on for 1 second and off for 1 second. The total duration of the treatment will be 26 minutes 40 seconds, but the actual UV exposure will be 13 minutes 20 seconds. In this, the Group C was again by the external in Group C there was a external supplementation of the oxygen was given, and the follow-up was done at day 1 and 6 weeks. The hyperbaric periocular environment was provided by a customized oxygen goggles prepared by a surgical universal precaution kit, where a hole created in the side of the goggles and tubing carrying 100% medical oxygen was delivered through the hole, where the hole was created on the opposite side of the eye which is getting treated. The oxygen rate was 1.5 to 2 liter per minute. The hole size was approximately equivalent to the head of the CXL system, that is around 10 to 11 mm. The primary outcome measures were demarcation line depth and visibility and spectral domain OCT, calculated at 6 weeks after the CXL procedure. The demarcation line depth measured in the center and 2 mm nasal and 2 mm temporal by using the inbuilt caliper tool. Along with the demarcation line visibility scoring was documented, where grade 0 where line is not visible, and if line is visible but measurement was not accurate, and whether the line is clearly visible. So these are the results. The preoperative pachymetry was comparable in all the 3 groups, and the depth of the demarcation line was about 250 microns in all the group, and it was comparable without any statistical significance. No complications were reported in any patient. The group 2 patients out of 15 in Group A has shown no demarcation line after 6 weeks, and the rest of the patients the line is clearly visible. Whereas in Group B, all the patients mostly have the line is clearly visible. Whereas in Group C, all the patients has line is clearly visible, and 2 patients have shown double demarcation line, where it is measured at 2 different levels. No complications were reported, but on postoperative day 1, where the epithelial staining was done, the first 2 groups are shown the diffuse punctate staining, whereas the Group C, where the oxygen has been supplemented, the staining with huge block covering cornea was reported in most of the patients. So these are the 2 studies which has taken the demarcation line depth as the effectiveness of the CXL system. So all the 3 protocols of TCXL are comparable in relation to depth of the demarcation line, and TCXL is comparable with the epi of CXL in relation to the demarcation line, and this study's finding approaches the typical demarcation line depth which was observed with the previous epi of CXL, and it is substantially greater than the average value reported from conventional previous epi-on procedure studies. But a larger randomized prospective study with a duration of 1 year and with other parameters were required along with the other CXL methods like EP of CXL to tell that the oxygen supplementation has better results. Thank you.
Thank you.
Nice study, Dr. Divya. So in one of the patients, like you got double demarcation line.
Yes, sir.
So what could be the possible?
I didn't find any.
Okay. Any speculations? All right.
That too only in the oxygen group it has got 2 patients.
Okay. All right.
And each group had 45 patients each, is
15
it?
patients, total 45.
Now, have you compared it to the lot of studies in literature where trans-epi effect is not as good as
Yes, ma'am.
this? So, what do you think the drawbacks there were, and compared to your study, why do you think the efficacy is similar in this study?
But previously there were no studies where the pulse with 26 seconds, 30 minutes, all were more accelerated. But pulsing and external oxygen was not there. But the study which has done the oxygen supplementation in 2022, it has shown the better results of
And was there
demarcation
any
line depth.
difference in that reticular haze, what you get post CXL in the 3 groups?
Yes, ma'am, we are documenting the densitometry to Shimflux, but we didn't evaluate the results.
And the vision drop post CXL, is it similar in all groups or?
It was same, no drop.
All right. Thank you.
So next is Dr. Nilima Balakrishna. She will be speaking on circling the cone, 360-degree intrasomal allogenic corneal segments.
A very good evening to one and all. Today I shall be presenting on circling the cone, 360-degree allogenic intrastromal ring segments. We have no financial disclosures. So the treatment options that we have available for keratoconus include modalities that are aimed at halting the progression of keratoconus, such as cross-linking, those that improve the visual acuity, such as intracorneal ring segments or phototherapeutic keratectomy. And for advanced keratoconus, we have DALK and penetrating keratoplasty. So the study was conducted at a tertiary eye care center in South India. It was a retrospective study. We had 10 eyes of 9 patients with advanced keratoconus, and cases with ocular or systemic comorbidities were excluded. So primary outcome that we considered was improvement in uncorrected and best corrected distance visual acuity. Secondary outcome, we looked for the change in the steep keratometry values and changes in the thinnest pachymetry as measured on Scheimpflug imaging. So for preoperative planning, we included patients who had large central cones as seen on Scheimpflug imaging, and minimum pachymetry of at least 400 microns were planned for the procedure of almost 360-degree case. Patients who had corneal scars or any posterior segment pathology were not planned for the procedure. The age group that we had, it ranged from 22 to 26 years, mean age of 24.6 years. We had 9 patients. 8 patients underwent unilateral implantation of the ring segment, and 1 patient had bilateral implantation. The mean follow-up ranged from 11 months and ranged from 6 to 18 months. Preoperatively, these patients had an uncorrected visual acuity of 2/60 to 6/60 with BCV of 660 to 618. Steep K was 47 to 60 diopters pre-op as measured on Scheimpflug, and mean thinnest pachy was 458, and mean minimum pachymetry in 7 mm zone was 560. So the procedure, we planned these segments with sizes from 320 to 360 degrees based on the morphology of the cone. And these segments were fashioned from preserved donor corneoscleral rims, which were then cut to the appropriate size by using circular trephines. And after the creation of the ring segments, femtosecond laser was used for the creation of intrastromal tunnels. And after the placement of the segments, all cases underwent accelerated corneal collagen cross-linking. The channel opening was closed with fibrin glue, followed by placement of bandage contact lens. No adverse events were noted intraoperatively, and all patients made an uneventful recovery. So this is the video which is showing the creation of the ring segments. And after placing the in this case we had implanted a complete 360-degree ring. After the placement of the ring in the channel, we'll gently nudge it into the position based on how the topography is and how the position of the cone is on Scheimpflug imaging. This is the post-operative image of the same patient. The position and depth is also confirmed with ASOCT post-operatively. All patients were given 0.5% moxifloxacin 6 times per day, and they were followed up post-operative day 1 month, 3 months, and 6 months. There was significant visual acuity improvement, both uncorrected as well as best corrected visual acuity. The maximum improvement that we saw was 5 lines, and out of the 9 eyes that we had, 7 eyes had at least 2 lines improvement in BCVA. Astigmatism reduced significantly, both topographic as well as refractive astigmatism. The steep K values reduced from preoperative to 1 month, 3 month, and 6 month, but the maximum dip was seen at the first month, and thereafter it stabilized. This is how the morphology of the cone is changing when compared to preoperative to 6 months post-operative period. So we can see that there is significant flattening, and there is also regularization of the topography. This is another patient. Thinnest pachymetry also increased in the postoperative period. Pre-op we had around 408. It increased to 423 at first month, 448 at 3 months, and 450 at 6 months. This is the pachymetry map. So here if we see, we can see that even the central area of the cone where no tissue is actually being added, even that is showing an increase in pachymetry, probably because of epithelial remodeling that is happening as a result of the implantation of the segment. So we used safety and efficacy parameters, and in refractive surgery, safety index showed 2.4 and efficacy index was 3.39, similar to what has been seen previously in intracorneal ring segments. These are a few postoperative images. So what our aim is with this procedure here is to combine the advantages of intracorneal ring segments while avoiding the various complications that can occur from them as a result of the PMMA that is being implanted. They work by Baracus law, and also in the ring segment that we implanted, another additional effect is the ring segment, because there is no point of discontinuity, so it can biomechanically be considered to be an artificial limbus which can potentially separate the load on the cornea to two separate compartments, thereby increasing the stability. There are various advantages to allogenic corneal ring segments. They provide improved tectonic stability, improved topography, and better quality of vision, and may play an important role in delaying or avoiding DALC. Our study has limitations of small sample size and small duration of follow-up, so we'll need prospective studies with longer duration of follow-up to see if the refractive effect is stable over longer periods. And we also need to look for preoperative and postoperative aberrometry to look for the quality of vision as well, and nomograms to assess the exact refractive effect with varied size and thickness of these segments. Thank you.
Thank you, doctor. That was interesting. But what we saw is, unlike the intacts or other rings, you create an entire...
So for this particular case that I showed, ma'am, since it was a complete ring segment, we created a plane. In the other cases, the channels were created.
But don't you think you're biomechanically weakening, because it's like a smile interface that you're creating?
Ma'am, because it is more superficial than a LASIK, it would not...
What is the depth of?
Ma'am, we keep it around 100.
Yeah. So it's similar to a LASIK flap. So that is something which would weaken.
Yes, ma'am.
And what is your CXL protocol post this?
Ma'am, we
3
give
milliwatts?
accelerated protocol, 9 millivolt per centimeter square for 10 minutes, 5.4 total.
Okay. Now
Epithelium off.
the other rings have their protocol. So what is your protocol? And you have made a chart as to when you choose a 360, 320, what depth and things like that? Or
Based
how
on
are
the
you?
morphology of the cone, ma'am, right now we are customizing, but we are planning to create, based on the refractive stability of these patients, we are planning to assess how to make a nomogram based on. Right now we've just seen the topography because there aren't any studies available previously on. There's only one nomogram that is proposed, and that is for shorter arc segments. Nothing has been proposed so far for such long arc segments in allogenic segments. So the ICRS segments nomogram is there.
Any adverse effect noted till now?
No, sir. In our series, nothing was there.
Your longest follow-up was?
Ma'am, 1 year.
1 year.
In the patients that we have in this series, 1 year.
And how long are they on steroids as of now? The 1
No,
year?
ma'am, we don't routinely give steroids to the patients. Only if we feel in the postoperative period there is significant inflammation, only then we give. Otherwise, they're not. They're just on topical antibiotics, and after antibiotics are stopped after the first week, then they're just on lubricants and cyclosporin.
Okay. Thank you.
Thank you. Thank you, sir.
So next is Dr. Neha Jain. She will be speaking on long-term study of Bowman's stromal inlay, refractive and tomographic outcomes in Tertiary Care Institute. Dr. Neha.
Good evening, everyone. So I'll be presenting a study where we are comparing the outcomes of Bowman stromal inlay and corneal collagen cross-linking in progressive keratoconus. So, as we know, based upon the maximum keratometry, thinnest pachymetry, BCV, and the clinical signs, we have a number of options available for treatment of keratoconus. One of which is stromal augmentation, which has recently been started. Of this, we had introduced Bowman's stromal inlay. This is a review of literature on stromal augmentation, and various reports have shown that Bowman's layer alone transplantation can also help in stabilization of ectasia and keratoconus. We had introduced this technique of Bowman's stromal inlay, where the Bowman's layer and the anterior stroma is inserted into the host lamellar pocket, and we've been doing this for the past 5 years now. But there is no study presently which compares the outcome of any stromal augmentation procedure along with cross-linking. So the objective of this study was to compare the outcomes of BSI with CXL. This was a retrospective, non-randomized, comparative and interventional case series which included 16 patients of progressive keratoconus. BSI was done in one eye, and CXL, according to the Dresden protocol, was done in the contralateral eye of the same patient. The minimum duration of follow-up required was 6 months to be included in the study, and the data was retrieved from EMR, and the topographic parameters were also noted in an Excel sheet for evaluation. This is a technique of BSI where an optically clear tissue is used, and the anterior 200 microns is harvested with the femtosecond laser from the donor cornea. An intrastromal pocket is created in the recipient using femtosecond laser, after which this tissue is loaded in an IOL injector and it is inserted in the recipient's stromal pocket. These are the surgical step in short. After the BS inlay is prepared, we may or may not customize this. In few patients, we've customized the inlay where PTK or PRK has been done on the stromal side, after which the recipient is prepared, and cross-linking has also been recently started after harvesting the inlay, after which the inlay is injected in the stromal pocket. The inclusion criteria is that we have included patients who have where one eye has been cross-linked and the other eye has underwent BSI, and please have a follow-up of 6 months. Primary outcome measures was to evaluate the changes in tomographic parameters before and after intervention in both the groups and compare the changes in tomographic parameters between both the groups. Secondary outcome measures were stabilization of ectasia, visual acuity, and complications of both the procedures. So coming on to the results, in the cross-linking group, we had 7 patients of stage 1, 5 patients of stage 2, and 4 patients of stage 3 keratoconus, whereas in BSI, we had 1 patient of stage 1, 3 of stage 2, and 9 patients of stage 3 keratoconus. So, in short, patients with mild to moderate keratoconus underwent CXL, whereas patients where the disease was more severe, that is, the Pachy was less, or the Kmax was higher, or the ocular surface was not that good where cross-linking could be done, they actually underwent BSI. The mean age of the patients was 19 plus minus 5.2 years, gender 5:1 ratio. Minimum duration was 6 months and maximum was 36 months. The p-value among the mean follow-up of both the groups was comparable to each other. In the CXL group, we found that the parameters before and after intervention were stable and none of the values had any significant changes. Whereas in the BSI group, the thinnest pachymetry increased after the procedure significantly, as well as there was an improvement in the Q value. The visual acuity remained stable before and after intervention in both the groups, and only significant difference was amongst the thinnest pachymetry and the asphericity. This is the median Kmax at different time points of study in both the groups, which shows that the Kmax was stable in both the groups, and the difference was that after CXL, the pachymetry decreased for a little while, after which it remained stable, whereas in BSI, it increased after the surgery. This is the change in keratometry after BSI for individual patients. We have drawn a graph here which shows that the red line, the line which I have marked with red, is basically showing a trend line which shows that the Kmax has almost remained stable after the surgery, and whereas in pachymetry, the pachymetry has increased in all the patients. This map compares the Kmetry in both CXL and BSI, which shows stabilization of ectasia. And in this map, we can see that after BSI, the pachymetry has increased from 460 to 583. This is of the longest follow-up patient of 36 months. This is a photograph of the patient who underwent BSI 36 months. The BCVA is 6/9 with contact lenses. No interface edema, haze, scarring or ejection episode was seen in this follow-up time, whereas after CXL, haze was observed in 2 patients. So the strength of the studies is the first study where a stromal augmentation procedure has been compared with the gold standard technique of CXL. It was done in the contralateral eye of the same patients, therefore reducing the minimum confounding factors to minimal, and the mean duration of follow-up of both the studies was also comparable. The weakness is the smaller sample size, retrospective nature, and a shorter follow-up. So in a nutshell, when we compare both of these procedures, there's a significant increase in pachymetry, better asphericity, and more regular tomography after BSI, whereas both the procedures actually stabilize the ectasia. But based on this study, that it appears that the tomographic parameters are more favorable after BSI. It can be done in patients where CXL cannot be done because of low pachy or unhealthy ocular surface. It may delay or avoid keratoplasty. Excimer laser ablative procedures can be done later if required for visual rehabilitation. CXL can be done later in case progression is seen, and because here we are actually introducing some amount of tissue inside the cornea, there is no damage to the keratocytes that is happening. The future scope will be doing a prospective study with longer follow-up. As the inlay contains keratocytes, there's a possibility of rejection in future, so we can actually start cross-linking of those inlays which be considered, and customized inlays can also be used in the future. So I would like to conclude that both CXL and BSI stabilize the cornea and keratoconus, and there's an increase in pachy and improvement in asphericity after BSI. Thank you.
Thank you, doctor. Again, very nice study. But you did say visual acuity, there was no change in this.
So actually there was not much change in uncorrected visual acuity, but if we compared with the contact lenses, the quality of vision had improved in patients subjectively. We have not actually taken a measure of it, so I have not included it here. But
these are again RGP lenses or scleral lenses or something like that.
Yes.
And was there any difference because the contour of the cornea is now changed? The Rose-K or the other regular contact lenses may not fit like would be in a cone. So was there any difficulties in fitting lenses after the augmentation procedure?
In fact, the patients, they subjectively felt that the ghosting of the images was lesser, or their clarity was sharper after the surgery.
And there was no. And what is your steroid protocol post?
For 6 months, we give steroid every month tapering. We start
after
with
that
6, and
stopped.
then after 6 months we stop.
Okay. And was there any difference in eccentric versus central cone or PMD cases? And have you studied the cone
I'm
location?
not included in this, but generally what we realize is that the central and steeper cones, they are generally doing better. But we are actually conducting a comparative study right now to actually make a conclusion regarding that.
All right.
Okay. Thank you.
Thank you.
But they were comparative cases. Can I ask a question?
Yes, please.
Do you think they were comparative cases as per your results?
Actually, CXL in this particular study has been done in where the patients have lesser severity.
That's exactly what I saw in your
BSI has been
results.
done in more
So
severe.
they are not
Comparable.
comparative cases in case selection. So the results may not be comparable.
Yes, maybe. But because
Because the basic patient profile is not the same.
it is done in the contralateral eye of the same
Agreed,
patient.
but the
yes.
conus is of different
Yes,
grading.
It is done in more severe. BSI has been done.
Exactly.
So next is Dr. Shivam Sharma. We will be speaking on alterations of mitochondrial genome in keratoconus patients.
Good evening, everyone. I will be presenting on alterations of mitochondrial genome in keratoconus patients. So keratoconus is thinning of cornea and irregular astigmatism resulting in diminution of vision. It basically bilateral and asymmetric nature of the disease. It will affect all the ethnicities and both the sexes. It usually occurs in second and third decade of life and progress until fourth decade. The exact etiology, specifically molecular etiology of keratoconus, is unknown yet. There are studies which shows that there is an increasing imbalance in oxidative stress and mitochondrial function in keratoconus corneas. These are some important clinical signs of keratoconus: the Munson sign, Rizzotti sign, Fletcher rings, and Vogt striae. Coming to pathophysiology of keratoconus, there is fragmentation of Bowman's layer, thinning of stroma and its overlying epithelium. There are folds or breaks in descent membranes. There are variable amount of diffuse corneal scarring, and there is collagen disorganizations. So mitochondria is the semi-autonomous organelle of our eukaryotic cell present in cytoplasm. There are 4 compartments. One is outer membrane, inner membrane, intermembrane space, and the matrix region inside the inner membrane. This cellular organelle have their own DNA and the protein machinery. So the main function of mitochondria, as we all know, is the production of cellular energy in the form of ATP through oxidative phosphorylation system. But there are other functions such as cell signaling, apoptosis, metabolic pathways like beta oxidation, and many more. So mitochondrial damage and oxidative stress starts with many possible trigger events like UV radiations, environmental factors, eye rubbing, any gene mutation, which will lead to the formation of superoxides or free radicals. Now in keratoconus cornea, there is a production of abnormal antioxidants and lipid peroxidation enzymes, which cannot be able to remove or encounter reactive oxygen species or reactive nitrogen species, which will lead to the accumulation of oxidative damage. That oxidative damage or oxidative stress will react with DNA, proteins, and phospholipids, and ultimately to the mitochondrial dysfunction and apoptosis and maybe corneal thinning. So it will again link to the abnormal oxidative phosphorylation reactions, which again will lead to accumulation of reactive oxygen species, and it's maybe a interlinking chain. Whereas if we can see in normal corneas, there is a production of proper normal antioxidants and lipid peroxidation enzymes, which will eliminate or remove the reactive oxygen species or reactive nitrogen species. So there may be no oxidative damage and no mitochondrial damage. So our aim of this study is to sequence the entire mitochondrial DNA to identify any mitochondrial DNA mutations and single nucleotide variations in keratoconus patients. We recruit total 10 keratoconus patients in this study. Their blood and cornea from same patients were collected for the genome sequencing. DNA was isolated by DNA-easy blood and tissue kit, followed by their agarose gel electrophoresis and library preparations. Then whole mitochondrial genome sequencing was done on the libraries by Illumina High Sequence X sequencer. Coming to the results, these are the demographic details of keratoconus patients. There is male preponderance in the study. The mean age is 21.98 plus minus 9.8. There is a 40% family history of keratoconus with the best corrected visual acuity of 0.32 at Longmar scale. And majority of the keratoconus patients, like 50% of the patients, are from IT sector. So they may have a more screen time, like 8 to 10 hours during a day. These are the DNA concentrations of all the blood and tissue samples that we have isolated, followed by their agarose gel electrophoresis to check the integrity of those DNA samples. Then coming to the results of nucleotide sequencing, out of many variations, these are some important and documented variations which we see in the other ocular diseases. Like 750 is very common variation, which there is a variation of adenine to guanosine, and we found out of 10 patients, we found both blood and tissue of 6 patients at these variations. Similarly, at position 4769, 10398, 11719, 16223. So there are many variations in the mitochondrial genome of these keratoconus patients, but these are some important mutations, and there are some novel mutations also. So depending upon the different type of mutations, there are major two types. One is transition, where purine is converted to another purine, and the transversion, where one purine is converted to another pyrimidine. So in our results, there is 234 variations of transition type, whereas 152 of transversion type, and 36 were insertions and 7 were deletions. So after the sequencing results, we also look the mitochondrial morphology of cornea, these keratoconus corneas, through transmission electron microscopy, and we found well-defined nucleus and normal intracellular spaces, but again the mitochondria are damaged or dysfunctional. The star mark shows degenerated cristae in mitochondria and numerous damaged mitochondria. So coming to discussion and conclusion, this is first of its kind of study to provide the information of mitochondrial DNA mutations in the Indian population of keratoconus. There are many variations found in the mitochondrial DNA of keratoconus blood and corneal tissues. Majority of the variations found are novel, and rest of the variations are reported in the pathology of numerous ocular and systemic diseases. We also found the irregular morphology and very less number of mitochondria in cells of corneal tissues of keratoconus patients. So this is a pilot study which demonstrates how mitochondrial damage may contribute to keratoconus. A larger cohort of patients are needed to evaluate mitochondrial DNA mutations as a genetic risk factor, indirectly contributing to the development or progression of keratoconus. Thank you.
Thank you, Doctor. Congrats being one of its kind study. But what is the clinical implications you're looking at? Because this is quite a, it's not a very
Currently,
cost effective.
Yeah, it's a basic science, basic study, which may contribute to the clinical aspect in future if we found any important mitochondrial mutation that may get directly linked to the keratoconus. So we can develop a treatment gene therapy for that also.
See, but broadly speaking, earlier eye rubbing and sleeping postures was one of the prospects, but now we all are very sure with our clinical experience that is one of the main reasons. So can that cause a mitochondrial changes, and what you're seeing in the mitochondria just an effect of it? Or what is it? Because we know majoritarily it's eye rubbing, genetics is less.
That is environmental factor, but we may know at molecular level maybe mitochondria are already damaged. Before.
Or could this be an effect of the friction?
Yeah, maybe.
Yeah, so that is an important conflict. Unless we divide that, it can always be a molecular change because of the friction itself. Yeah. And then it may not be of etiological.
Because in normal corneas, in normal population, they also rub eye at maximum time, but they did not develop any keratoconus or corneal ectasia.
No, they would probably eventually.
No, but there are studies.
So you can do similar study on some other, group of patients who are not keratoconus.
We are planning on doing control studies for refractive patients and other.
Yeah, then maybe it will give an added value.
We are planning to take this study on large scale.
Thank you.
Thank you. So next is Dr. Deepinder Chauhan. So he will be speaking on significant progressive corneal flattening after corneal cross-linking for keratoconus.
So with this presentation, we come to a full circle, and it's nice to see so many young people. I have this experience of maybe around 15 years of cross-linking, and we don't need any introduction to cross-linking, and now so many variations in the technique. So what I am talking about is basically what happens to these corneas many years after we have done a cross-linking. So most of the studies have shown that it's a very safe and effective procedure. Most of the studies have a duration where they have studied it for maximum 3 years. I found across one study in which they have studied the keratoconus post CXL of duration more than 6 months. And if you look at the data here, you will find that again by the end of 3 years, their cohort size had actually reduced from 233 eyes to just 30 eyes. And if you look carefully, by the end of 4 years, and in fact by the end of 6 years, only 4 or 5 eyes were all that they had left for the study. And interestingly, they have shown that by the end of 4 years, 4 of the eyes had shown a regression of around 5 diopters in the Kmax. So still we don't have very long-term data on the outcome of it. So I'll be just presenting a few examples of our patients who have had undergone CXL more than a decade back. So in summary, I'll be presenting data of 5 eyes of 3 patients. All had an age group of more than 25 years at the time of treatment. All were male patients. We followed the standard protocol, and all of these patients had no systemic illness, any collagen vascular disorder, everything was ruled out. They had a very uneventful post-op period, and interestingly, most of them had an advanced or moderate keratoconus with Kmax more than 55. So case 1 is right eye, 10 years follow-up that I am presenting here. Pre-op, they had a Kmax of 56. This eye had a Kmax of 56.6, and by the end of 10 years, the flattening had was at 46.7, so showing around 9.9 diopters of flattening at Kmax, and the steep K also showed a flattening of 12.5. Also, there was a steep fall in the central corneal thickness, and the central corneal thickness had the minimum Paki had shown a fall of 105 microns. So this is the summary where the steep K shows a flattening of 12.5 diopters, and the cornea shows a thinning of more than 100 microns. The other eye of the same patient was not a very advanced keratoconus, but had a similar outcome, although it was less remarkable than the other eye, and overall flattening that you see see here is around 6.4 diopters, but correspondingly the amount of thinning was quite staggering, and it was again 118 microns. None of these cornea had a very significant scarring. Yes, you can appreciate a mild haze in the center. So coming on to the next patient, again the right eye, 13 years of follow-up, you see a flattening of more than 8 diopters along the flat K, and interestingly there was no significant thinning in the cornea. It was around 382 to begin with, and it was around 385 to end with. The other eye of the same patient had again a very remarkable flattening effect. You can even see that apart from the flattening, you can see a permanent striae and the posterior stroma or the Descemet's level, although the thinning was around 65 microns. Case 3, again only the left eye was operated, and again you see the same story with the flattening of 10 diopters and the thinning of cornea by around 47 microns. So to summarize, all cases on average they had a flattening of around 8 diopters and a thinning of around 17 microns. It's interesting to see that it was not the steep K that was showing higher flattening. It was actually the flat axis which was showing more regression. Obviously, all these patients, after a honeymoon period of when the corneal keratometry had come down to 44 or 45, they all showed hyperopic shift later on. Obviously, they had a fall in best-corrected spectacle visual acuity, and no response to topical steroids or cyclosporin was seen in between when they were coming for follow-up. So if you look at an interesting pattern, in case 1, or you see a drop of around 4 diopters in the follow-up duration of around 2 to 4 years. Later on, you can also appreciate that the other eye of the same patient, after initial 2 to 3 years of stability, you again see a sudden progressive flattening of the cornea. Case 2, right eye, again after 4 years, you see that the corneas have dramatically started to flatten. Again, the other eye shows almost the same duration, there is a flattening effect. And again, the last case 3, left eye, you again see that by around 4 years, there is an unexplained flattening of the cornea which is happening. So what is happening, that the flattening is accelerating in the later half of the decade, and till the last follow-up, you don't see any signs that it is showing any stopping. So we have a progressive regression of keratoconus here. Okay, that is something which is quite baffling. Now, higher flattening and deep stromal striae had a correlation. The patients who had a very significant flattening, you can appreciate the fixed striae that you see. Is it that those corneas which had shown maximum amount of thinning, was it that you also saw the maximum amount of flattening? Well, not really. In the same patient, in the first eye, you can see that case 1, left eye had a maximum thinning and least flattening, and in case 2, right eye had no thinning at all, and yet it showed a flattening of around 8.5 diopters. There are 2 studies in which, in fact, 2 case reports that you can see in literature. One was in a case in which there was an obvious corneal scar, and that led to the flattening of cornea. Interestingly, there is one case series in which 3 patients were studied, and long-term follow-up showed that none of these had any significant scarring. One case had no thinning, but they all showed a flattening of around 5 to 10 diopters. So to summarize, although these are isolated case series, all of these patients have been operated by me. They have been followed up regularly. They have been studied extensively for any likely cause underlying. But I am at a loss to explain why there is a progressive flattening. And this is something that we all can go back to our initial cases, keep a track of these patients, how they are doing. So I am now a little more skeptical when I am doing any additional procedure to my patients who are undergoing CXL, whether it is any inlays or whether it is any additional laser treatment. So that is a spanner and a spoiler, but this is something that in long term you might encounter. What happens to these patients who were operated maybe 2 decades back? So with that I would conclude. Thank you.
Thank you. So interesting collection of cases. But now that these were all, I suppose, from the Dresden's protocol when we were doing the 3. So now we have switched to accelerated, do you still see such flattening?
Well, we don't have that long a data. We switched over to accelerated CXL around 5.5 years back. We are seeing some patients showing the same trend, but again, for a long-term data, we need to really wait to what happens to these patients.
Yeah, but at least I think in the general trend, we are not seeing this sort of haze and flattening now with accelerated.
Exactly.
So probably in Dresden's, we are killing or over-treating the collagen.
Yes, it could be true. It is also interesting to see that if the Dresden protocol was really at fault, what triggers the flattening in the later half, like after 4 or 5 years, you see that with graph, you see a sudden dip.
Correct.
So that is something which is not easily explained. Also, if there is a scar, maybe with time the scars, they tend to reduce in their opacity and they tend to stabilize, but here you don't see any hint of stability which is coming.
And have you done all this on the Pentacam, sir, or which platform?
Pentacam.
It will be interesting to also look at the densitometry at each stage, so then we can correlate the scar.
And you can see there's a little bit of haze. The densitometry does show that, but again, what is baffling is why is it still progressing? So it's the reverse, like you want it to stop, it's kind of not stopping, it's kind of going back.
So how many the total patients like?
So again, these are just case series. We are looking back at the data which is more than 10 years old. Okay, obviously these are rare examples. They are not something which you expect in a normal, course of disease or course of post-operative period. But you might encounter these patients, but because the number is small, obviously they usually tend to get overlooked, as I showed in one of the studies in which they have at the end of the study they had only 6 eyes, and all of these 6 eyes are basically the patients who are still following up with them, and they had a flattening of around 6 diopters. So there will be definitely a proportion of patients who might end up on the wrong side.
But we also, again coming to the same institute, we also saw that some of the cases where we did a phases protocol, sub
400.
This protocol in thinner corneas, which were like 320, 330. So we got 4 of those patients with more than 1 year follow-up, and in those patients we've seen exaggerated response. I can't explain how and why, but they were really advanced cones. Pre-op, they were less than 6/16 with vision wise, and now the patients are very happy because vision has improved to 6/24, 6/18, and while we told them nothing is going to happen, but this kind of a response is there also in thinner corneas.
Yeah.
And we used only there the CXL was 3 milligauss is used for 10 to 30 minutes per month.
Yes, maybe a true way to study would, now we know haze and scar also causes progressive flattening. So maybe we should separate patients who have that little haze and remove them from the study, and only the non-haze, those are the actual flattening which is actually happening. Because in many papers when we also look through, because I have a big series of similar flattening, they have put cases with haze and scar and taken them into the study. So obviously because Pentacam is an optical thing, they're even the pachymetry and everything is biased with the scar. So maybe if we have a group and remove the high densitometry and actually look at the clear corneas which progress, then maybe some reason why it's actually flattening. Even in a person, both eyes dressed in, one eye behaves different, the other eye behaves different.
Yes.
So that's again we really don't know why.
So did you find any correlation between the haze and the amount of flattening?
Yes.
Because these patients, the haze is not increasing, but the
there are
flattening is continuing.
few patients which are clear, still huge flattening, but the ones with the scar are keep flattening, and as you said, they become hyperopic.
Right.
So they have their honeymoon period and now come for plus classes.
So,
so those are typical with Dresden.
Right.
I have seen none with the last few years of accelerated.
That's a good news if accelerated doesn't have that much of flattening. But yes, again, time will tell.
True.
Wait.
But I think the first 5 years, if you have not seen, it's unlikely that.
So these are the ones which showed a dip after 4 years.
Yes.
So that is which is more scary because you felt that it's done and dusted, but now it is coming back.
Yes. Sure. Thank you, sir.
Thank you.
So next is Dr. Kusumita. She will be speaking on tear biomarkers in advanced keratoconus subjects with scleral contact lens uses.
Good evening, everyone. I'll be speaking on tear biomarkers in advanced KC patients. There is no financial interest. As keratoconus was traditionally described as a bilateral asymmetrical non-inflammatory corneal ectatic disorders, but these days it's a multifactorial disease with multiple pathophysiological issues, and recent studies have implicated a low level of inflammatory components detected in the tear films of the KC patients, such as inflammatory markers, matrix metalloprotease, etc. And also progression of these KC patients are associated with high amount of irregular astigmatism and higher order abrasions, where glasses would no longer be effective, and scleral contact lens would help in such cases. These scleral contact lenses are, as we all know, it's a large diameter gas permeable lenses with tear reservoirs that vault over the cornea and the limbus, and thus help in correcting the irregular astigmatism. The tear fluid reservoirs in these lenses also hydrates the cornea and mechanically protects the ocular surface from the shear force of the lids and the environment. But our main concern was the minimal tear exchange and the prolonged wear time that is under studies where very few research has been made. However, few studies also say that the contact lenses can trigger the innate immune system and release the cytokines and chemokines. Therefore, this tear fluid analysis can act as an important source of information to analyze this ocular physiology and homeostasis. So our study aimed, which had a primary objective to assess the tear biomarkers in pre and post contact lens wear in advanced keratoconus patients, also to assess the visual acuity and ocular surface after scleral lens usage. It was a single center prospective study done in our contact lens clinic. After written informed consent taken from all the subjects, we included patients above 18 years with advanced keratoconus stabilized who are willing to wear scleral contact lens, excluded those patients with progressive keratoconus or having any ocular surface disorders or any systemic medications which are anti-allergic or anti-inflammatory drugs. So once the patients were recruited, the baseline examination was done, Schimling imaging topography was done, ocular surface assessment was done, and tear samples were collected using a micropipette from the lateral 1/3 of the lower fornix with minimal irritation without any anesthesia, and the samples were cryopreserved. Scleral fitting was done and the samples were collected at the follow-up at around 6 months follow-up, and the ocular surface assessment was repeated, and the samples were analyzed using multiplex ELISA method, and these were the markers that we analyzed in our study. Moving ahead to the results, the mean age group was 24 years, and the Kmax value was mean Kmax value was 72 diopters with a thinnest PACU of 389 micrometer. The scleral lens that we had used had a DK by T value around ranging from 100 to 141 with a mean tear vault of 288 and the mean wear time of 8 plus or minus 2 hours. And we observed the visual acuity improved significantly with from uncorrected to best corrected with contact lens. Moving ahead to the ocular surface characteristics, it was observed most of the ocular surface investigations showed improvement, like tear stability improved, staining reduced significantly. OSDI also improved significantly. Tear osmolarity also was reduced significantly. Moving ahead to ear markers, we analyzed interleukins like interleukin 4 and 8. Interleukin 4 showed slight increase in the interleukin 4 post contact lens wear, and interleukin 8 was reduced post contact lens wear but not statistically significant. Matrix metalloprotease, as we all know, that it is the enzymes involved in extracellular matrix degradation, and usual upregulation of these enzymes are noted in keratoconus tear films, and these enzymes were analyzed pre and post, and it was observed the MMP7 was increased post scleral contact lens wear, and it was significant, whereas that of 9 and 10 was reduced but not statistically significant. tissue inhibitors of matrix protease 1, 2, 3 and 4 were analyzed, and there was no much change except TIMP3 levels, which was slightly higher. This is a summary of the tier biomarkers of various interleukins matrix protease. There was slight upregulation of most of the enzymes with significant level in interleukin 7 and 3 TIMP3 levels. However, there are no studies justifying the elevated levels of these biomarkers. Apart from that, our secondary outcome was to see the visual acuity on the ocular surface, which improved significantly after scleral contact lens usage. But the limitation of our study was a smaller sample size, shorter duration of the study, and the tear fluid reservoirs we couldn't collect it. Adjuvant analysis of the fluid reservoir may give more information of the tear biomarkers. So to conclude, it helps in visual and therapeutic rehabilitation in advanced keratoconus patients with minimal impact on the ocular homeostasis. Thank you.
So what was the main question to your mind in this study?
Sir, there are studies the pathophysiology of the keratoconus is getting broadened, and we are seeing like tear biomarkers are the main will help us. Tear film analysis will help us to know the pathophysiology, and we also know there are certain targeted therapies are under trial, and keeping this in mind, and also considering the scleral contact lens usage is being more frequent for visual rehabilitation. So we want to know any homeostasis change, and so that further it may help in the targeted therapy or the future studies.
Did you study the parameters related to keratoconus also?
Keratoconus stabilized in these patients. Topography we want to study. The data is under retrieval.
But these are post-CXL patients, or
few are post-CXL stabilized advanced keratoconus patients.
And these were like full scleral, or what was the diameter of your lens?
The diameter varied between 15 to 15.8, 15 to 16.
So mini scleral.
Mini scleral lenses.
All right. Thank you.
Dr. Kameshwar
I think
is
it's
here?
not there.
He's not here. Okay. Can conclude.
Good. Thank you. I think we got to see some very good innovative work, nice case presentations, and thanks to one and all.